Good morning, bonjour, bon dia. Welcome to the WHO Africa Media Briefing, which is taking place in collaboration with the APO Group. First, some housekeeping. We have interpretation in English and French. Please go to the right hand bottom of your screen and select click on the globe icon and select the language you prefer. Yasmina, please.
Oui, bonjour à tous et merci de nous avoir rejoints à cette conférence de presse de l'OMS. Si vous souhaitez écouter la conférence en français, merci de cliquer sur l'icône en forme de globe qui est située en bas de l'écran à droite. Merci.
Thank you, Yasmina. So today, she just have an emergency this morning, and she sends her sincere apologies. She's not able to join us, so she's really sorry about this. So in her place, we have Dr. of University of now to introduce our remaining panelists.
Okay, good morning and good afternoon to all journalist colleagues participating in this press conference on COVID-19 in Africa, including the vaccine rollout. I'm very pleased to be joined for this conversation by Professor Jean-Jacques Muyembe, the Director General of the National Institute for Biomedical Research in the Democratic Republic of Congo, and Technical Secretary of the National Multisectoral Committee for the Response to COVID-19. He will speak about vaccine rollouts in the Democratic Republic of Congo. Professeur, bienvenue à cette session. I'm also happy to welcome Dr. Gitindi Gitahi, the Group Chief Executive Officer for AMREF Health Africa, who will share with us how communities are responding to the lack of access to vaccines. The current surge in new COVID-19 cases in Africa is easing off, but with 108,000 new cases, more than 3,000 lives lost in the past week, and 16 countries still in resurgence, this fight is far from over. Health workers, services, and communities can and should use this time to regroup and prepare for the next wave. With end-of-year travel and festive celebrations fast approaching, fresh increases in cases should be expected in the coming months. Without widespread vaccination and other public and social measures, the continent's fourth wave is likely to be the worst, the most brutal yet. Yesterday, I joined governments and private sector leaders, international organizations, and other partners for the global COVID-19 summit convened by the United States. Everyone in attendance committed to three goals: vaccinate the world, save lives now, and build back better. This is the kind of international solidarity that will help to end this pandemic. The United States and governments attending the summit put forward a number of concrete actions, including for countries to urgently convert those sharing pledges into deliveries, and for all countries to vaccinate at least 70% of their population by 2022. They also called for solutions to solve the oxygen crisis, to eliminate the testing gap, and to make sure all countries have access to safe and effective therapeutics. This amplifies the message that we as WHO have been promoting throughout the pandemic, along with a growing number of our global health advocates. What is needed now are strong accountability mechanisms to ensure these targets translate into real and concrete results in countries, and that promises made are promises kept on sharing vaccines. You will agree with me that actions speak far louder than words. Global coordination mechanisms are needed to bring together vaccine-producing nations, manufacturers, international organizations, and other stakeholders to promote transparency on vaccine delivery schedules and sharing of other key critical information. This will help countries to plan and roll out the vaccines efficiently. A key finding from the interaction reviews in our countries of the rollout to date is that the instability caused by inconsistent vaccine supply is negatively impacting vaccine uptake. At the same time, we know that vaccine supplies are increasing. So our message to countries is really to get ready by strengthening the capacities required to pick up the pace of vaccination. WHO teams are in the field to closely work with our partners and countries to accelerate this pace. For the rollout so far, we're starting to see what works and what does not work. What works is something like the approaches such as diversifying vaccination sites, bringing them to places that people frequent regularly, like churches, mosques, or markets. Getting information close to the community through religious leaders, women's and youth groups, leveraging networks that are already well established and that community trust. These are some of the things that we see are working in countries. Financing remains vital, including international mechanisms to facilitate rapid access to the catalytic funds that will help countries to roll out the vaccines faster. As it stands, 1 in 3 people globally are fully vaccinated against COVID-19. But in Africa, this drops to 1 in 25. COVAX deliveries are still coming into African countries, with 4 million doses arriving in the past week. These shipments are greatly appreciated, but it's concerning that only a third of the doses pledged by the end of 2021 have been received. The pace of vaccination in Africa must rise by over 7 times to around 150 million per month on average to meet the global goal of vaccinating 70% of every country's population. This is huge, and it will need to be accompanied in equal access by adequate delivery capacities, staff, supplies, funding to massively ramp up the rollout. It is in every country's interest that this happens quickly. The longer the delay in rolling out the vaccines, the greater the risk of additional challenges emerging, be they variants, hesitancy, operational gaps, or other threats. So I look forward to our fruitful discussion today, and thank you very much for joining us. Back to you, Mary.
Thank you very much, Dr. Benito, for that elaborate introduction. To you, Professor Muyambe, can you please tell us the challenges that the DRC is facing in terms of vaccine deployment? Kindly also highlight the importance of rich countries delivering on their promises that they have made in terms of vaccine shipments. Professor Muyambe, please.
Merci beaucoup pour la parole. Et comme vous savez, la COVID-19 est une crise globale avec des conséquences au-delà du secteur de la santé. La solution à cette crise doit aussi être globale. La vaccination est l'une des solutions, pourvu qu'elle soit équitable et atteigne toutes les populations exposées. Or, les données actuelles montrent que la vaccination n'est pas équitable. Certaines régions de la planète sont plus vaccinées que d'autres. Les pays africains sont victimes de cette inégalité vaccinale, due entre autres au non-respect des engagements des pays riches qui, au travers du mécanisme COVAX, avaient promis de soutenir la disponibilité des vaccins aux pays à ressources limitées comme les pays africains. C'est ici l'occasion de rappeler aux pays riches de matérialiser leurs promesses concernant l'appui aux vaccins. Comme disait le docteur Tedros, directeur général de l'OMS, l'inégalité en matière de vaccins est le principal obstacle qui empêche le monde de mettre fin à cette pandémie et de s'en relever. Alors, les défis que mon pays présente, ce sont les défis qui sont liés surtout sur le plan de la communication. Il y a une forte résistance de la population qui est liée à l'infodémie. Et comme vous le savez, cette pandémie survient au moment où les réseaux sociaux jouent un rôle très important dans la communication. Le deuxième défi, c'est l'utilisation des vaccins avec une date de validité très courte. La population considère la courte validité de 3 mois de certains vaccins comme synonyme de mauvaise qualité. Alors, la population n'adhère pas, n'est-ce pas, à ce vaccin. Un autre défi, c'est l'indisponibilité des coûts opérationnels. Quand les vaccins sont arrivés, il fallait mettre ça il fallait les distribuer sur le terrain. Et comme vous savez, la RDC, c'est un pays très vaste. Et pour atteindre les coins et les recoins du pays, il faut beaucoup de moyens. Il faut beaucoup de moyens. Et ces moyens manquaient au moment où les vaccins, n'est-ce pas, sont arrivés, où même le décaissement des fonds mobilisés était vraiment très faible. Alors, l'autre défi, c'est le faible engagement politique. Parfois, des hommes politiques émettent des messages qui n'encouragent pas la population à adhérer à la vaccination. Donc, tous ces éléments mis ensemble, nous avons eu des freins vraiment à mettre en pratique, à déployer les vaccins sur le terrain. Et donc, il y a un effort considérable à faire de la part d'abord des pays riches qui doivent disponibiliser, n'est-ce pas, les vaccins, et de la part, n'est-ce pas, des autorités locales, des citoyens que nous sommes, pour sensibiliser la population et rompre ces défis, cette hésitation qu'a la population pour recevoir le vaccin. Et tous ces mécanismes que le prédécesseur a cités, donc l'utilisation des influenceurs, les églises, les sociétés civiles, tout ça c'est très important, mais il faut arriver donc à les convaincre et à mettre en place tous les mécanismes pour que la population accepte la vaccination. Merci de m'écouter.
Merci beaucoup, Professor Muyambe. And to you, Dr. Gitahi, please tell us about the impact of vaccine scarcity on communities in Africa and what your reflections are on the outcome of President Biden's global COVID-19 summit.
Thank you very much, Mary, and thank you to the participants, Dr. Manido and Professor Muyembe. Very quickly, the first thing is obviously that the COVID-19 pandemic has affected communities significantly. We know that the economies are suffering, women have lost jobs, men have lost jobs, there have been rising gender-based violence, rising teenage pregnancy related to school closures that are following the waves. And this will continue to go on until we can vaccinate the African people. So the way to actually socio-economic recovery for the continent is to vaccinate rapidly. And I think this is what has been reflected on, in the previous conversations. Right now, only about 6% of our people across the continent have actually had the chance of getting a dose of a vaccine. And yet the continent carries about 17% of the global population. So this is holding back a significant part of the population through all these challenges, including the challenges that we have seen of a high case fatality. I was looking at data recently that shows that case fatality in Europe, if you look at the average case fatality or in terms of number of deaths related to the number of reported positive cases, it has dropped by almost 67% if you look at the average versus the current case fatality vaccinating almost 60% of the population. So we know that vaccines work, but the African case fatality rate remains above the global average, remains at about 2.5%. Yet we know that in communities, there are many unrecorded positive cases. There are many unrecorded deaths that happen as community. Not many of us understand that the people who get recorded as positive of COVID or having died are those who are visible. Many people are not visible because they couldn't afford a test or they couldn't afford to seek care. As you know, Africa doesn't have universal access to health services. That's why we are fighting for universal health coverage together with WHO globally and even here with WHO Afro. It's because the people, when they get sick, they don't seek care because they can't pay. So many who die at home because they had low oxygen and they didn't go to the hospital and they collapse at home, don't get reported in hospital statistics in many of the countries. They get reported as cases of the police because they need to investigate the cause of death. And because we don't have widespread COVID testing, post-mortem COVID testing in Africa, we miss many deaths that are related to COVID-19 that we will never know because they died and they were taken to the mortuary by police because they died at home. This is the continuing socioeconomic pandemic, and the way to end it is to vaccinate as many Africans as rapidly as possible, which then brings me to the point about the summit that you asked. Within the, in the summit, we had conversations regarding, as was said by Dr. Benito, around vaccinating the world, saving lives now, and also building back better. And many pledges were made, including an addition of 500 million doses pledged from the US government, from President Biden. That brings the total pledges by the US government to about 1.1 billion. I think the key concerns are that these doses need to come now. We know that the previous 500 million doses that were pledged by the US government, only about 1.5 million of them have been delivered. And therefore, the new pledge needs to be on the back of delivery of the old pledge, because a vaccine delayed is a vaccine denied. Community people are dying as they wait. So we don't want this death to continue. We want the vaccine to come in time. And as Professor Moyembe has said, we want the vaccine to come in time and long dated, not short dated, because when they are short dated, they put pressure on the vaccine delivery system. Therefore, the first thing to say out of this particular summit is that we appreciate all this, the donations that were pledged by the rich countries and those who have doses to offer. We truly appreciate that. But we call for commitment to deliver on those and also to deliver on them in a timely manner. Secondly, is that there was a commitment to raise $10 billion to enable vaccination efforts, including overcoming hesitancy, communicating, as was reflected on earlier. Again, this needs to be done and done rapidly. The next point that was made is that these doses need to come through the COVID vaccine facility. It is extremely important that we prioritize the COVAX facility. The COVAX facility has so far delivered over 80 million doses in Africa, more than half of the doses that have been received here in Africa. It is important because the COVAX facility delivers the doses for free to governments, as opposed to the efforts to actually give loans to countries to buy vaccines. We don't want to increase the debt of countries based on purchasing vaccines, when actually the COVAX facility has over $10 billion and they can purchase 4.5 billion doses if the rich countries can allow COVAX to come ahead of the queue. That should be our collective call. Allow COVAX to come ahead of the queue and then ensure that COVAX can purchase the doses and deliver them equitably to these countries. In terms of saving lives now, the reflection was largely around oxygen and all these things that are being donated. My insistence is that let us build local health systems, because a nurse right now looking for oxygen will not call Global Fund, will not call WHO, will not call AMREF, will go to their local store and check whether oxygen is available. So we really need to strengthen local health systems, strengthen their local capacity to finance themselves, and strengthen community accountability mechanisms. So we appreciate all the donations and commodities, but we want to call for building health systems. And that was my call at the summit yesterday. And finally, as I close, is on the area of building back better. I am concerned personally that we are trying to build new mechanisms while mechanisms already exist. The Global Health Threats Council, which was actually recommended during the summit, is a duplication of WHO. We want WHO to be supported to be the one that is handling global health threats and to be supported with funds so that even the suggested Global Health Security Financial Intermediary Fund, which was mentioned and supported at the summit, that should have a seed funding of $10 billion. And then there was a suggestion that should go to Alban. I think the mechanism should be found for WHO and existing other mechanisms like Global Fund and others to be able to handle these funds so that we don't create new global architecture. We build and support existing global architecture. I would like to stop there and I'll talk more during the questions. Back to you, Mary.
Thank you very much, Dr. Gitahi. That call for vaccine equity and accessibility for African communities definitely is very important. So you have now heard from all our panelists. It is now your time, journalists, to ask your questions. To do this, please use the Q&A function on the Zoom platform. Give us your name, the name of the news organization you have to have your questions asked. If you would like to go live, indicate on the Zoom platform as well. On hand to also answer your questions are Dr. Tiano Balde, who is the incident manager here at the regional office for the COVID-19 response, and Dr. Richard Mihigo, who is always here with us, the immunization and vaccine development coordinator here at the regional office. So I would like to start with Rhoda. I understand you want to ask your question live. Are you there?
Morning, Dr. Mary. Yes, I'm here. So my name is Rhoda Odhiambo from the BBC. My question can be answered by either Dr. Mihigo or Dr. Balde. In regards to the UK's move not recognizing vaccine certificates and the approved programs that African governments have put to roll out COVID-19 vaccines, what does the WHO make of this move? Because it looks like a trust issue. And the greater implication of this is that it will hurt the continent's vaccination campaign.
Okay. Dr. Richard, you can start, and then Dr. Muyembe. Dr. Benito, if you want to weigh in, you can also weigh in after they have responded. Dr. Richard, please.
Yeah, thank you, Dr. Mary, and thanks for the colleague from BBC. I think we have to differentiate two things here, and I think there have been some confusion in the press the last couple of days about this announcement by the UK. First of all, we need to mention that all the vaccines that are being supplied through COVAX in the African region are vaccines that are WHO pre-qualified, that have received the emergency use list authorization by WHO. And these are the vaccines that are safe, efficacious to be rolled out in the country. Part of these vaccines, as we have heard even from Dr. Gitahi, are vaccines that are coming through donation, including vaccines that are coming from the UK and used in several other countries in this region. So we're not really here talking about the integrity of the vaccination programs in Africa. That has been a program that have delivered very efficient vaccination campaign even before COVID-19 started. So I think on that side, we need to be very clear that vaccination that are currently taking place in many countries, in all the countries in Africa, follow the right procedure using the right vaccines to protect the people in Africa. Now, the issue of vaccine certificates is completely a different issue. And I think that we need all collectively to work together to see how some of these certificates that are generated from countries could be mutually recognized by different countries. I know that Africa CDC was working in collaboration with partners in the WHO in digitalizing some of these documents to make sure that people can move freely and the certificates that are produced by the countries are also trusted abroad. So as you said, it's mainly an issue of trust. And I think we need absolutely to work around that to make sure that those certificates that are generated from national program are genuine, are valid, and can be mutually recognized by other countries. Thank you.
Thank you, Professor Muyembe.
Oui, voilà, je pense que le fait que les vaccins que nous recevons en Afrique sont des dons, disons, la population a une certaine méfiance pour dire est-ce que ces vaccins sont vraiment des vaccins, sont les mêmes que les vaccins utilisés en Europe et ailleurs. Bon, nous, en tant que scientifiques, nous disons que ces vaccins sont les mêmes, ont les mêmes capacités, ce sont vraiment les mêmes vaccins homologués qui sont donnés ici en Afrique. C'est à nous, donc, les scientifiques, de convaincre les populations pour que la population adhère à la vaccination. Il n'y a vraiment pas de raison pour que les mauvais vaccins soient envoyés en Afrique et les bons vaccins restent, n'est-ce pas, en Europe. Il n'y a pas de raison pour cela. Donc, nous avons confiance en ces vaccins et nous les donnons à notre population. Voilà.
Thank you, Professor Muyembe. Dr. Benito, do you want to weigh in on this?
Mary, I think there are discussions that are going on between WHO and the UK government. We will make sure that we closely work with the UK government to ensure that a solution can be found quickly to resolve this issue. So as soon as new information is made available, we'll be happy to share that with our partners, journalists, and member states. So that's what I can say at this point in time.
Thank you very much, Dr. Benito. Daniel from CGTN, are you there?
Yes, I'm here, Mary.
Go ahead.
Yes, Mary, my question goes out to WHO. Now, many nurses are going through compassion fatigue from repeated exposure to people suffering from COVID-19. Now, some of the nurses have unfortunately succumbed to the virus after being in contact with those who are still hesitant to get inoculated. Now, what can countries do to protect the lives of hundreds of healthcare workers who tirelessly put their lives on the line to save us?
Okay, Dr. Benito, I will start with you. Then Dr. Richard and Dr. Gitahi could complement after you. Dr. Benito, please. You are muted. Okay.
Thank you. I mean, first of all, we need to recognize, to acknowledge the tremendous efforts being done by nurses across the continent to really make sure that they are taking care of those who are sick. that's something we need to really acknowledge and appreciate the great work they've been doing over the past months. Now, in terms of what needs to be done at country level to ensure that we protect them, we avoid this burnout, I think the first thing is really to make sure that all the PPEs and other life-saving and protective commodities are available. When they need them, they should have it. And I think a lot of work has been done by WHO, member states and partners to make sure that they have those critical life-saving commodities. So that's in terms of protection. But also in terms of training, I think a lot is going on to ensure that they are well trained. They make sure that they try to, I mean, we're trying to make sure that even in terms of mental health, they are being supported. And then lastly, it's really in terms of making sure that adequate, or say, supplies and psychological support is given to them, because we've been closely working with our member states to ensure that they get what they really need, and that is work ongoing, and WHO will always be there to ensure that we also protect all these healthcare workers while they are supporting the ongoing COVID-19 response.
Thank you, Dr. Benito. Dr. Gitahi, please, do you want to weigh in on this question?
Yeah, thank you for that, Dr. Marian. The points made by Dr. Benito have my full support. I just want to add that if we can accelerate vaccination of health workers, ensure every single health worker is actually vaccinated, that is the best way to actually protect health workers, because we have lost nurses, we've lost doctors, we've lost laboratory technologies, we've lost community health workers. So the biggest effort I would like to add there is to ensure they are vaccinated and they are given priority in every country, but also includes overcoming their information concerns, because even health workers have information concerns, because not everyone understands vaccines the way some of us may understand them. So even those health workers need to be educated, because also once they have a full information on the vaccines, they also become key opinion shapers for the communities to overcome any doubts that may be there for vaccines. So I would just like to add that that's the next, that should be our focus actually, in addition to everything that has been said. Thank you.
Thank you very much, Dr. Gitahi. Dr. Richard, you can add on that previous question, but I want to give you a question first. And if you have addition, you can complement on the previous question as well. This question is from Delphine. The question is, can you please tell us how African countries have reached, how many African countries have reached the 10% vaccination target? You can answer this in French, please. Dr. Richard.
OK, merci. Merci beaucoup. Non, pour la question précédente, je pense que mes deux prédécesseurs ont bien parlé, donc je n'ai rien d'autre à ajouter. Et pour la question de Delphine, jusque les données à la date d'hier nous montrent que 14 pays dans la région africaine ont à ce jour vacciné plus de 10% de la population de manière complète. Nous sommes à une semaine de la fin de ce premier milestone important qui est fin septembre 2021, où tous les pays sont censés avoir vacciné jusqu'à 10%. Donc, nous espérons que dans les jours qui viennent, avant fin septembre, nous aurons probablement 2 à 3 autres pays qui pourront dépasser la barre de 10% de la population complètement vaccinée. Malheureusement, la majorité des pays dans notre région ne vont pas atteindre cet objectif. Et nous avons encore des inquiétudes nombreuses pour le prochain milestone qui est de vacciner 40% de la population d'ici la fin du mois de décembre 2020. Donc, nous espérons que les conclusions du sommet d'hier, le sommet global sur la vaccination d'hier, vont accélérer les efforts des pays à recevoir des vaccins en quantité et en temps voulu pour éventuellement aider les populations à être vaccinées et que nos pays puissent atteindre ces objectifs importants fixés par la communauté internationale. Merci.
Thank you very much, Dr. Richard. Professor Muyembe, there is a question from Chris from CGTN. He's asking, when will the Madana vaccine be deployed in the DRC?
Oui, nous avons déjà reçu, je crois que c'était la semaine passée, nous avons déjà reçu un lot important de vaccins Moderna qui est déjà utilisé ici à Kinshasa, et il reste donc à déployer en province. Et très prochainement, donc, il sera envoyé dans les différentes provinces. Ce que nous voulons également, c'est garder, n'est-ce pas, l'équité. Pas seulement garder les vaccins dans la capitale, mais également dans les provinces et surtout les provinces les plus reculées. Et donc, ça se fera très prochainement. À vous.
Merci beaucoup, Professor Muyembe. This question is coming to you, Dr. Gitahi. The question is from Esther Nakazi. She's asking, what is the shelf life for most of the donations coming to Africa? That you talked about a long time frame is required. So what is the ideal time frame? Dr. Gitahi, please.
Well, thank you very much. And I would like to ask Dr. Mihigo to assist me on this because he's following tracking the vaccines properly. But what we know is that there are many vaccines, and most vaccines will be up to 6 months, expiry or life. But there are many that are landing in Africa with just a month to spare or 3 weeks to spare. And that's a real challenge because you can imagine, as you've heard Professor Muyembe explain, Madana has arrived, it needs to be distributed from the national depot, then it needs to go to the regional depots, then go to the facility. That in itself takes time. And then there is vaccination. And in many of the areas in Africa, majority of the populations are rural, and some of them may be very far from the health facility. And these vaccines are not amenable to taking them to the people because the cold chain, they are not like polio vaccine that you can actually deliver through community health workers all the way to the doorstep. So people need to come to the facility so far. And that means that you have to mobilize people coming from very far. So this is why we are saying for our health system, our delivery mechanism, it needs the absorptive capacity requires is suboptimal and therefore requires long-dated vaccines. This is really the issue we need to address. And I don't think we should receive vaccines that are less than 2 months to expiry. I don't think it would be optimal. But I'm sure Dr. Mihigo has probably a more scientific answer than this.
Dr. Mihigo, please.
Dr. Gitai is right. Unfortunately, this has been quite a very tricky situation. When we did an analysis on the average in terms of shelf life for most of the vaccines that are coming as a donation, unfortunately, this range between 2 to 3 months on average. This is quite very short, and we've heard Professor Muyembe saying about the trust that this is really causing in terms of the community that are accepting this vaccine. Some countries have even completely refused to receive some of the donation when the shelf life was shorter. Although we have seen countries that have high absorptive capacity that have indeed having a lot of challenge, but have accepted that. So in summary, I think what we are asking really the donating countries is that we have not only vaccine that are extended shelf life, minimum up to 6 months. Secondly, that we have a minimum of predictability when these vaccines are coming and how many doses are going to come. So that will help countries to plan accordingly their campaign, to put in place a deployment plan well in advance before the vaccine arrives. Because most of the time, the news around donation comes in a very short notice. We communicate to countries, are you ready to receive a vaccine in a couple of days? And most of the time, countries do not have enough time to prepare for that. So I think to change this paradigm, we will need really a bit more predictability in terms of number of doses, how many doses are coming, and when they are coming, to help countries to plan accordingly. Thank you.
Thank you, Dr. Mihigo. I have an additional question for you. Are there extra efforts by African governments to get more vaccine outside the COVAX arrangement?
No, absolutely, absolutely. If we looked at the number of vaccines that have arrived in Africa, we are around 180 million doses that have arrived in Africa. And so far, vaccines that have came through the COVAX facility are around 65 million only. So the vast majority of the vaccine came through either bilateral deals by the country themselves or bilateral donation between countries on Africa. So there is a lot of efforts that countries are doing in parallel of the COVAX mechanism. But what, again, we would like to see, it's the increase of these numbers of doses, the predictability, and we hope to see the number of vaccines that are going to come through the AVAT platform, which is the AU-led initiative, also to increase quite very quickly so that we can augment the capacity of countries to deploy vaccines.
Thank you very much, Dr. Richard. The next question is coming to you, Dr. Balde. So the question is, how much have other health issues like malaria, cholera, and other outbreaks been affected because of the attention that has been shifted to the COVID-19 response?
Thank you, Mary, and thanks for the question. I think that question was also asked last week, and definitely we know that this is really a major burden. I mean, the COVID-19, given the scope and also all of the magnitude of the pandemic in Africa, is really mobilizing all of the different resources. I mean, health resources, public health resources for responding to this pandemic. We have seen it during the third wave, and while responding to this pandemic, we have also faced many other challenges, many other emergencies currently which are ongoing. Recently, we just closed the Ebola EVD outbreak in Guinea, but also the Marburg outbreak, I mean, equally in Guinea. But we are also the humanitarian crisis where we have a major component in terms of public health. So for sure, I think the trade-off and the balance between, I mean, sharing all of the available resources for responding timely and effectively to these different emergencies is really a major challenge. So this can create a kind of tension to our health system, I mean, to our capacities to respond to all of these different emergencies. However, we have to say, I mean, a lot of actions are ongoing today, like for instance, like in DRC with the meningitis outbreak in the Chopo province. I mean, we are trying to respond to that one by supporting, obviously, the national health authorities of DRC. Same thing for the Tigray, I mean, the humanitarian crisis in Tigray, the situation in Madagascar, with the malnutrition situation in Madagascar. So just to conclude, in average, usually we have more than 100 public health emergencies occurring in Africa, I mean, in a yearly basis. So this is, I mean, coming just in addition, I mean, to this situation. So definitely it's really a major tension, and as an implication, definitely more engagement and more capacities, I mean, to respond effectively, timely, and concomitantly to all of these different emergencies is something which is really important. And we call upon, obviously, all of the different organizations, agencies, and also obviously the national health authorities, I mean, to put our hands together, you know, for really, I mean, using all of these, I mean, limited resources, I mean, adequately. Thank you, and back to you, Mary.
Thank you very much, Dr. Balde. Yes, the DRC is indeed a very good example of a country dealing with COVID and so many other emergencies. Professor Muyembe, do you want to weigh in on this? How is DRC managing to deal with all these emergencies in addition to the COVID-19 response?
Bon, nous avons en RDC une grande expérience. Nous avons une grande expérience pour aborder toutes ces crises. Quand vous avez une crise d'Ebola qui dure 3 mois, 6 mois, on étouffe un peu les autres activités. surtout, n'est-ce pas, les activités n'est-ce pas, du PEV, et vous aurez donc la résurgence de l'épidémie de rougeole, de choléra, etc. Mais ce que nous faisons actuellement, c'est d'intégrer donc notre lutte contre la COVID dans les systèmes de santé, c'est-à-dire nous remettons ça au niveau des zones de santé. Et les zones de santé vont donc travailler en tenant compte des autres maladies comme les paludismes, comme la rougeole, qui sévissent, n'est-ce pas, dans les zones de santé. Donc, tout cela est intégré et nous faisons donc une activité multisectorielle. Notre riposte est multisectorielle, de sorte que les autres ministères participent également et font tout pour qu'on n'oublie pas les maladies endémiques qui sont en fait les principales causes de mortalité et de morbidité, n'est-ce pas, dans la population. C'est donc en tenant compte de ça. Donc, il faut que vraiment notre réponse soit incrustée, n'est-ce pas, dans les systèmes de santé et surtout donc au niveau des zones de santé. Voilà un peu comment nous voyons les choses. À vous.
Thank you very much, Professor Muyambe. Dr. Benito, do you want to weigh on this question, please, dealing with COVID and other emergencies?
Well, I think the reality here is while all countries are experiencing this COVID-19 and responding to the COVID-19, there are other health emergencies and other public health matters that are going on. And like Balde was saying, if we take the example of DRC, Guinea, and other countries, they are experiencing, in addition to COVID, other public health emergencies, being meningitis in DRC, and recently it was Marburg in Guinea, and then plague in Madagascar. So clearly, there's an impact of COVID on the response to some of these events, but the good news is with the experience countries have acquired in preparing for and responding to acute public health events in the region, we are closely working with them to ensure that while addressing the COVID-19 response, we also focus on other emergencies. One of the typical examples is like what is happening in DRC with the meningitis, where we have been able to closely work with Professor Muyembe's team and the MOH to deploy a number of experts who are closely working with them in Guinea, for instance. Some funds were made available for what we call our contingency fund for emergency. So I think the key message here is, yes, we are really busy working on COVID-19, but let us not forget other public health priority in the region and make sure that we also address them in a manner that deserves the attention of WHO, member states, and our key partners.
Thank you very much, Dr. Benito, sorry. Yes, it is indeed important to address all the different emergencies because we could have mortalities from other emergencies, even more than COVID as well. So the next question is to you, Dr. Richard. It's coming from Ismail Kabuyaya from Congo Unicom. How long do the various vaccine side effects last? Should those who already had 2 doses expect a 3rd dose like they are doing in some European countries? What is the vaccination rate in Africa? So you go first and then Professor Muyambe can complement.
Okay, thank you, Mary. Well, I think we, on the first point on side effects, I think what we have seen with the pharmacovigilance system that we have established in collaboration, of course, with member states when the vaccine started to be deployed, and the data that are being collected, that's in the vast majority of the case, the side effects that are following immunization are very mild. These are small pain at the place of injection, a little bit of some fever, which usually disappear in the next 24 to 48 hours after the vaccination. So I think in the vast majority of the case, this is the situation. We are more and more data that is showing a very good safety record for most of the vaccines that have received WHO authorization for emergency use. Now, with regards to the 2 doses, for those who have already received 2 doses, again, here it's very important to note that with the vaccine effectiveness data that are now coming from the field after the deployment of the current vaccine, we are showing that those who have been completely vaccinated are more likely to not get the severe form or even when they are hospitalization. So it protects them really against those severe outcome of the disease. And there is no evidence for the moment to say that people who are fit, who are in good health, that they need a 3rd dose. So there are more and more data that's showing that the 3rd dose could potentially be given to the people who are either having some issues of immunocompromised, or for some of the elderly where we know that the vaccination immunity could wane with the time, particularly when they are in contact with some of these new variants. So in conclusion to this, we are more and more, we are continuing to advocate for people to receive the full course of vaccination, because this is what will protect them against severe disease and hospitalization. And then finally, with regard to the rates, vaccination rate, we are still very far, very far. If you recall the question by the colleague from in French, we say that only 14 countries as of today have reached 10% of their population. On average in Africa, only 4% of the people have received the 2 doses of the vaccine. So we are really very far to reach the ideal coverage rate that one could expect. And we hope that in the coming weeks, with the number of doses that are going to increase, we may accelerate the pace of vaccination to protect as many people as possible. Thank you.
Thank you very much, Dr. Richard. Dr. Gitahi, do you want to weigh in on this question? Looking at the dosages, can we take the 3rd dose? What is it that we need to do in Africa? Professor Muyambe, I will come back to you with another question. Dr. Gitahi, please.
Thank you, Dr. Mary. I think the first thing to say on what Dr. Richard has talked about is over 6 billion doses or close to 6 billion doses have been given across the world. And there has been no crisis of side effects. If there were major side effects, by now we would have known, 6 billion doses is a huge number. You'd have expected, if as the disinformation is going around saying, oh, this is going to do this, and we would have seen it. We haven't. So vaccines are safe. And, reflecting on what Dr. Mihigo has said. The secondly is that we know that even where countries have tended to think about giving a 3rd dose, which WHO has discouraged and said, hold on the 3rd dose until everyone has their 1st and 2nd dose. It's like queuing for food, and the person ahead of the queue is going for their 3rd plate of food, but the people behind the queue are still waiting for their 1st chance to serve their food. So this is what we are saying, let people hold on, let people get their 1st and 2nd dose. And then when there is enough science of the 3rd dose, that's going to be advisable and policy across the world. And then we can then apply that policy to available resources. But for now, we need to avail the available doses to people to receive their 1st and 2nd dose. That would be what I would like to add.
Okay, and then what about your thoughts on the vaccine hesitancy here in Africa in the communities?
Well, I think this is a really important question, Dr. Mary, because globally, if you talk to people in rich countries, if you talk Europe and North America, this question keeps coming up. And in my view, this question is being asked by people who actually don't understand that the challenge of vaccines in Africa is not a demand problem. It's a supply problem. And that needs to be the headline. that the challenge is a supply issue, not demand. The fact that we have a few pockets of hesitancy, that is expected. And vaccine hesitancy is not an issue of COVID, it's not new. In fact, if you look at hesitancy in some of the countries in the north, it's actually much higher than the countries in the south. We know that in US, they're dealing with a huge issue of hesitancy and lack of vaccine acceptance. So I think for us, the headline should be that vaccines should be made available. It's a supply issue. Demand will be overcome for those few people who still have questions through communication, through information, through trusted sources, like now we are doing here, that people listen to trusted sources and they get the right information. So the current problem we have in Africa is actually supply, not demand.
Thank you very much, Dr. Gitahi. And Professor Muyembe, this question is coming from the news organization AFP about the management of vaccine in remote areas. Are there arrangements made to vaccinate populations living in conflict-affected areas, like what DRC did during the Ebola outbreak? Professor Muyembe, please.
Bon, voilà, je pense que dans les zones de conflit, nous avons aussi une grande expérience pendant la crise Ebola de 2018-2020. Pour la première fois, nous avons utilisé donc un vaccin qui demandait une conservation à moins 80. Et les vaccins RVSV que nous avons utilisés, donc il fallait absolument les garder à moins 80. Et malgré le conflit qui existe à l'est du pays, dans la province du Nord Kivu, Sud Kivu et Ituri, nous avons donc pu vacciner plus de 600 000 personnes. Donc, en utilisant un vaccin qui demandait une conservation comme le vaccin Pfizer ou le vaccin Moderna. Et cela a bien marché. Et maintenant, nous avons cette expérience et nous voulons également introduire le vaccin dans la province du Nord Kivu, qui est en fait le deuxième épicentre de la COVID en RDC. Le premier épicentre étant la ville de Kinshasa. Et donc là, nous allons utiliser les différents vaccins. Nous avons opté pour notre plan stratégique l'utilisation d'au moins 3 vaccins, au moins 4 vaccins, donc AstraZeneca, Moderna, Pfizer et Johnson & Johnson. Et si nous utilisons donc le Pfizer, il faut absolument une chaîne de froid de moins 80. Et là, nous pensons, nous avons déjà l'expérience dans cette partie du pays. Nous allons donc utiliser ce genre de vaccins. Nous pensons que nous avons vraiment eu une grande expérience avec Ebola et dans n'importe quelle région de la RDC, nous sommes capables de nous déployer et de vacciner la population. Mais je pense que si nous comparons donc le vaccin COVID avec les autres vaccins que nous utilisons, la population est plus habituée au vaccin du PEV. Au vaccin du PEV qui s'adresse vraiment aux enfants. Et nous n'avons pas cette habitude de vacciner les adultes. Et le vaccin COVID arrive au moment où il y a l'infodémie, etc., et qui s'adresse surtout à la population adulte. C'est ça qui fait qu'il y a une méfiance, l'acceptation n'est pas facile, il y a beaucoup d'hésitation, et nous pensons que si on travaille beaucoup sur ceux qui ont des hésitations, ils peuvent basculer soit du côté positif, donc ils acceptent le vaccin, soit du côté négatif. Mais l'expérience que j'ai maintenant, je vois que de plus en plus en RDC, surtout ici à Kinshasa, il y a un engouement. Depuis que le président de la République s'est fait vacciner, nous voyons un engouement pour accepter la vaccination. Et nous croyons que dans les jours à venir, toutes les doses que nous allons recevoir seront utilisées, d'autant plus que nous avons développé une expérience avec ce que nous avons reçu dans la première phase. Maintenant, en troisième phase ici, le personnel soignant, je crois que c'est prioritaire. Il faut absolument protéger le personnel soignant et également le personnel de la police et le personnel militaire qui sont en contact permanent avec la population. Ça, il faut vraiment absolument rendre même cette vaccination obligatoire. Et ici, dans mon institut, nous sommes en affaire de 150 agents. De plus en plus, nous parlons de la vaccination obligatoire pour venir travailler au laboratoire. Voilà un peu comment nous voyons les choses dans l'avenir. Voilà.
Thank you very much, Professor Muyambe, for that elaborate answer. Yes, indeed, we can leverage on our experience responding to outbreaks in the past for this COVID-19 response and future outbreaks. So we are coming to the end of this briefing for today. We will turn back to our panelists for their final words. You have 1 minute each. I will start with you, Dr. Gitahi, then Professor Muyambe, then finally Dr. Benido.
Thank you very much. I think I would like to conclude by just looking at a recent study on this issue of vaccine acceptability. And I think we need to speak about vaccine acceptability quite a lot, because we have seen people queuing for vaccines. There may be pockets of hesitancy, and those are easily overcome by information from trusted sources. In a recent study, in Mozambique, the vaccine acceptance was seen to be somewhere around 90%, Sierra Leone around 90%. The lowest out of about 10 countries was Burkina Faso, below 70. Of course, I know DR Congo, as Professor Muyembe has mentioned, even in a previous 15-country study, had actually shown a much lower acceptance, and this may be related to the experiences of Ebola, trust between the people and their government and all these things. But when you look at countries like Russia, acceptability was seen to be 30%, US 64%. So basically the point I'm making here is let's focus on supply and then make sure we isolate where those pockets of hesitancy are, because again, hesitancy is not absolute. It is a demand, it's a desire for information, and then overcome them through community structures, local leaders, health workers, as we continue to insist on supply and rapid vaccination of our people. That's what I would like to say in closing. Thank you.
Thank you very much, Dr. Gitahi. And Professor Muyambe, your final words, please.
Bon, il y a un point que nous n'avons pas abordé, en fait, c'est la recherche. La recherche va nous orienter s'il faut prendre une troisième dose de vaccin ou pas. C'est-à-dire, dans mon institut et également à l'école de santé publique ici à Kinshasa, il y a de plus en plus de recherches sur la séroprévalence, n'est-ce pas, des anticorps dans la population vaccinée et non vaccinée, pour voir exactement ce qui se passe. Et ceci est très important pour nous, pour prendre donc des mesures, n'est-ce pas, de santé publique, s'il faut faire une troisième vaccination ou pas. Tout ça, c'est la recherche qui va, n'est-ce pas, nous dire ce qu'il faut faire, n'est-ce pas, dans l'avenir. Merci.
Thank you very much, Professor Muyambe, for that useful addition on the issue of third dose. And now finally to you, Dr. Benido, your final thoughts, please.
Thank you, Mary. 3 points. The first one is really on COVID-19 vaccination and vaccines. I think there's a need to accelerate the pace of vaccination in the region. We should also take advantage of the ongoing momentum and global momentum to ensure that we can accelerate the pace of vaccination. We'll be closely working with our donors and partners to ensure that more doses can reach our countries. The second aspect is really the fact that there are quite a number of other health emergencies that are going on in the region, including dengue, plague, and so on. So our member states and partners should be closely working together to ensure that while responding to COVID-19, we also closely look at what is happening in other health areas, and then we address any gaps we'll be seeing. And then lastly, it's really the issue of healthcare workers, which was also raised here. We need to make sure that they have what they require in terms of PPEs, trainings, and vaccination, as well as information that can help them better perform and save lives. So these are like the three points I'll convey here. And I'd like also to really take this opportunity on behalf of Dr. Moeti to thank Dr. Gitahi, to thank Professor Muyembe and all our colleagues, journalists who have taken time out of their busy schedule to attend this briefing session. Once again, many thanks to you on behalf of WHO Regional Office for Africa. Back to you.
Thank you very much, Dr. Benito. A very big thank you to all, including yourself and the journalists, all our panelists. Thanks for the excellent work everyone is doing. It's a busy time, it's a challenging time, but we all have contributions and roles to play. So thanks everyone, thanks to our journalists, thanks to the panelists once again. See you next week.
Thank you very much and bye-bye.
Merci. Au revoir.
Au revoir.